Top Med Talk.
Well, hello and welcome to Top Med Talk. We are in Prato, Italy for the 7th Collaborative Clinical Trials in Anaesthesiology. We were here back in 2019, I think was the last time that we've been at the meeting doing interviews. I have to say, probably one of my favorite guests is back to join us again. But before we introduce him, I'm Desiree Chappell. I'm your host of Top Med Talk, and I'm joined by our former, you're still the founder, but former editor-in-chief of Top Med Talk, Monty Mythen.
Desiree, thank you for letting me back in the chair.
That's all right, Monty. So I think you've been back to this meeting since.
I have.
Yeah, back in 20...
Exactly, the first post-COVID meeting.
It was.
Which was excellent. Again, this is a very, very special meeting.
While we were here in 2019, we were able to catch up with a friend of yours, but a new friend to me, Professor Bruce Biccard. Bruce, thank you so much for coming back and sitting with us again here in Prato.
Thanks, Desiree. Thanks, Monty. It's so nice to be here.
Yeah. So when we were here in Prato the last time, I believe that you were talking about and reporting the results from the ASOS-2 study, if I'm correct.
It was the ASOS study, so the original study, which was just documented how poorly the patients were doing. That was the first time we spoke together on Top Med.
Is that the first time? That's right.
You guys were legends. You communicated the message.
We didn't see the pandemic coming at that stage clearly from either you style, because the next time we spoke was in our so-called Pockapalooza in July 2020. Which was when we were having a virtual meeting in London.
Yes, and Pockapalooza, for those who may not know or have listened to in the past, was our perioperative care Palooza Fest, right, Monty? Whenever we were all online, we were kind of stuck at home, and we were able to chat with our friends around the world. And Bruce, you'd come on and you were talking with us and Salome Masawami.
That's correct.
Yes, and about maternal mortality and the work that you guys were doing together. Monty?
Well, we made a decision because we'd put it on free open access, and 8,000 people turned up, which was great, virtually. But we asked them, rather than buying a ticket, to consider donating to SAPORG, which they did.
Very kind. They helped support our database and data administration, which has been really important. We've been lucky. I think we've had about 5 impactful projects.
Yeah.
And they've all been run through that single database, so thank you.
Yeah. Well, let's just step back for just a moment. For those who may not have listened to at this point, hopefully you will go back and listen. But if you haven't, tell us a little bit about SAPORG and the work that you've done in ASOS-2, and further work that you've done recently.
So SAPORG stands for African Perioperative Research Group. It's a group of clinician investigators across Africa from more than 40 countries. Nearly 2,000 clinician investigators. It's essentially unfunded. So it's clinicians who believe in trying to make a difference to perioperative outcomes. The work has been firstly just observational work. So we did ASOS, African Surgical Outcome Study, looking at outcomes in adult surgical patients.
Yes, that was the first one that you did here in Prato that year. That's
correct. That just showed that if you had surgery in Africa as an adult, you're twice as likely to die.
Yeah.
A very high failure to rescue as well. And then the maternal cohort from that, the mothers were 50 times more likely to die than high-income countries, mainly hemorrhage. And then we went on to try and address failure to rescue. That was ASOS-2. And the idea was if we could flag the high-risk patient and make the clinical team aware of that high-risk patient on the ward post-operatively, they would pick up the complications earlier and intervene and decrease mortality. The reality is such a simple idea didn't work, sadly. It was an immense effort, nearly 30,000 patients, 332 hospitals across Africa, stopped at the start of COVID.
Mm-hmm.
The interesting thing was that the SAPORG group believed that the concept for decreasing failure to rescue was correct.
Yes.
It was just the execution was very difficult. So we've continued to work on that. We work on that as a quality improvement project now with the Institute for Health Improvement.
Mm-hmm.
We've gone through first phase pilot, trying to work very pragmatic tools. now we're about to go into the second pilot phase. And then if we get that right, then we'll try and go across the continent.
Bruce, could you expand a little bit? Do you think it was failure to detect the deteriorating patient or failure to effectively treat the now detected deteriorating patient?
The data we were collecting was very sparse, so we can't really identify where we failed. We had, fortunately, a process evaluation linked to ASOS2, and that was, fortunately, through Rupert Pierce and Tim Stevens, helped us get that into ASOS2, and that really was important because it showed a lot of things that I suppose as clinicians I wasn't really locked into, things like teamwork and hierarchy and all these other factors besides just clinical expertise and identification and appropriate intervention. So it's taken us right back to the drawing board and working through all those sort of things, like how teams work and how the clinical space works.
Like a change management piece as well to that. You really have to focus on how you can get buy-in from the teams to, implementing whatever it is, the interventions.
I think the biggest challenge for these sort of interventions, in particularly low-resource environments, which is a massive community, is that we need to learn how to do it without it being resource-heavy.
Mm-hmm.
And so quality improvement is resource-heavy. Like lots of people, lots of checking in, lots of tools. And so we're trying to work out a way to how we can do it in a light-touch way, which is effective.
And the treatments required to rescue in the very well-resourced world, if we look at recent work from Australia, would they be affordable? Because it seems you needed IV crystalloid solutions and a vasoactive agent, and that would solve, in a timely fashion, 90+% of the problems.
You touch on a very important point. Probably a lot of the failure to rescue is those simple early interventions, which have been missed, and then they go on to result in more serious complications, which result in death. So if our sort of unpublished work at the moment shows that if you're an adult and you have surgery and you die, half of them, the population attributable risk is sepsis.
Mm-hmm.
And so there's certainly an opportunity, there's a time opportunity for intervention. So it's just probably preventing that progression to that severe infection that kills the patient. It's different, though, in mothers and children.
Mm-hmm.
So mothers, almost half the population attributable risk is hemorrhage. And that is just quick.
Yes.
Those are quick deaths where if you miss them, it's too late. And kids, I'm not sure yet, but I suspect it's also going to be more those acute deaths. So we did a ASOS beads. The mortality with kids is 11 times that of high-income countries, but we've got a whole critical incidents data cohort from that as well. But we haven't started analyzing that. But I think that'll also be very helpful in understanding, where to intervene with pediatric surgery.
So, Bruce, through all of this work that you have done and your passion for improving healthcare in Africa, you've written a book. Tell us about that. You've signed mine. I just want to say thank you so much for signing our book, Safer Surgery for Africa. So tell us about this.
Yes, thanks, Desiree, and thanks, Monty. You two were key in communicating our early message and getting it out to the world, and we most appreciative for that. But I think what's happened is, the group has become very aware of what the problems are in Africa and feels a big responsibility for improving them. What I was finding quite distressing is that we know what's happening, but in reality, the people who can really affect change don't know that it's happening. So this was an advocacy project. It's really trying to communicate what we know for the public so that they can say, it's unacceptable that my mother died during a cesarean section, or my father dies when he goes for surgery. Yeah, it is unacceptable. And I think the communities aren't aware of that. And my experience has basically as a medical student during the early days of HIV and lack of antiretrovirals in South Africa, really was experience in seeing activism in action. As soon as the communities understood that it was their right to receive antiretrovirals and that they impacted the disease, they forced change in South Africa, which is really quick by the pressure they put on governments. And I thought, if we can communicate how things are in surgery in Africa, it'll give people the leverage to have that power to be activists, a demand of governments what they should get.
The book is fantastic, and I please urge everyone to read it. One of the questions I had, because I wasn't around or wasn't practicing at the time, was it internal or external pressures on governmental agency and local advocacy groups that you felt really made a difference in the change in HIV? And is that something that, you're working in and outside of the country to do?
So the South African story, it was local communities who spent time educating within communities, and the communities really rose up and demanded, that we have access, and it changed government policy in South Africa. It was very powerful. I do talk a bit about it in the book, but I think it was that, power to the people, which I think is really important.
And Bruce, one thing I took from reading the book, which I'm still trying to get my head around if I understood it correctly, is it's affordable, is one interpretation I got from it.
Yes.
It's to provide equitable, reasonable healthcare, is not that expensive per capita. And the other thing, if I'm right in how I interpreted it, is you're saying that a government is actually up on the deal. The net balance for having a healthier community is the government books balance more effectively. Did I get those two things right?
Yes, I think you have got them right. The problem we have with surgery is that it doesn't have a silo like trauma and injury, infectious disease, non-communicable disease. So, when you finance health, at the moment they don't finance surgery in a way. But when you look at the data, lots of data that was prepared for the Lancet Commission on Global Surgery, you see about 30% of the outcomes have a surgical treatment component, and that's not factored into the funding. So yes, the book is about a lot of things, but there's a big section on finance, because I think finance is super important. It's not going to change until the governments change the way they view financing health and surgery, or they put a ring fence money for surgery. And the other part is, I think, the NGOs and that sort of group, which also help fund health, I feel they're not tracking what's happening. So, there's a rise in non-communicable disease and that, but the portion of money that's going to things where we're showing success continues to rise, but where surgery is so important that we're not seeing the funds follow those cancers and that sort of thing.
This comes back to the discussion about the money, but what I took from the book was, as opposed to they can't afford to do this, they actually can't afford not to do this.
Yes.
So let's get on with it. What can we do to help?
Ooh. What I would love to see is, I would love to see communities pushing governments to be more proactive, engaging with NSOPs, for example, the National Surgical Obstetric and Anaesthesia Plans. So, that's one thing. So then that makes a government interact with, how we're going to finance this, how we're going to change the workforce, etc. The second thing is, and I know this is always controversial, but the reality is that the limited amount of workforce in low-resource environments is huge. And we have to embrace task shifting, task sharing in the same way, in a safe way. And so that sort of thing is really important. And there's an example in the book in Tanzania, working on protection or an environment which provides a safe task sharing environment can really catapult their workforce in a safe way. And so these are sort of discussions I would hope that the book will start to create.
Yeah, that's fantastic. Bruce, in addition to the book, I mean, I don't know where you have all the time to do all this, but in addition to the book, you've also been able to work with a podcaster in Africa, correct? And create your own podcast series from this as well.
Well, I need to thank a few people for this. So the book I'd been writing for about 4 years, and it was going to die with me. And then the lead for Assos Beats, Alex Torborg, she said to me, you know what, you got to get that book out. And then she said, I've got a mate, Olivia Taylor, who does Earthcast, and she would help you do some podcasting. And I sort of tentatively said, okay. And well, Olivia moves very quickly. And in about a week,
oh my goodness,
it was all more or less set up, and she totally supported it. And I thought, it was a good platform because it was a platform outside of our community. And that's really what the book is about getting the message outside of our community. But what I didn't expect is she said, okay, if we're going to do these podcasts, I'll host the first one and talk to you. Then you'll host the whole series, and then I'll host at the end. Wow, you're crazy. But actually, it was an incredible experience. So what I did was I took the story of the book, and the book tells, surgery in Africa, but through the story of different people or people who've contributed to our understanding. And so I asked all the people as the story through the book goes if they would do a session. And everyone said yes.
Yeah.
And just talking to colleagues who amazing people all over the world who've contributed to, our understanding in Africa was fantastic. And if I had to pick one episode that everyone should listen to, I think it's the one with John Mira and Emmanuel Magassa. They were just fantastic.
Remind us what it's called, Bruce, so we can get it in the show notes and a link to it.
Yes, it's called Earthcast.
Earthcast.
And it's season 3.
And just as a little sneak preview about that particular pod, what was your favorite piece from that?
Oh, it's just listening to Emmanuel Magassa talk when he's just so passionate.
Yeah.
That's great.
So, Safer Surgery for Africa, available online?
Yes.
I managed to find it recently.
It's on Amazon.
On Amazon. It's a great read, very affordable. Now, it says here, Bruce, you've got a passion outside of all these things you do. Was it extreme cycling or something? Tell us about that, Bruce. It's good.
If you look in the book, you'll see my portrait picture. I look very tired. That was taken through during one of these ultra distance races. Yes, that's the one.
It's great. I think we're going to use that as the podcast picture for us this time.
An avid endurance cyclist. You also use this as your social media portrait.
Yes, I've changed. I'd never wear a tie, and so I've decided that's actually what I look
I think that very successfully put anyone off endurance cycling. So he's actually he's a good-looking young guy.
I know. That one, you look tired. Right?
You've got a race coming up in a couple of weeks, I think.
I'm doing a race called the Race Across South Africa. It's a beautiful ride. About 50 people do it every year. It's a route where you map the route and you use a compass. There's no GPS.
So you head off on your bike. Head off on your bike on your own, unsupported.
Yes, we go off in batches of about 8 people.
How far is it?
It's 2,100.
2,100 feet? Come on, 2,100 kilometers. Let's work that out. That must be 10 days to 15 days?
Yeah, if I did 15, I would be very pleased.
Yeah, and it's not on a road.
No.
That's what I was going to say. That's the other challenge of it.
Yes, it's mountain biking and portaging, but it's beautiful, and South Africa is a beautiful country. Great way to get
out. All your food and water, or do you have some support stations?
They're support stations, so they're farms, basically. They're probably a solid day's ride between each support station. Before the race, we send 2-liter ice cream tins to the support stations, and that'll have your maps and food to get to the next support station.
Got you. So 2,100. I think you almost finished it last time, is that right?
Oh, yes.
Is that when you took the picture? Oh.
It was actually, yes, during that race, yes. I messed up a bit.
In your own suburb, was it?
Yes, I was about 50 kilometers from the end.
Oh.
But I pushed the please come get me button because I hadn't been sleeping. I'd run out of food. And then I could see us making really poor decisions in an area where I felt fairly comfortable. And then I thought, no, it would be very bad form for me to be needed to be rescued.
Taken to your own hospital.
Yes. So I exited, unfortunately. Hopefully that.
Well, I think you got pretty close. Well, it sounds like it. Well, is there a way to follow you during this? Is there anything you're going to be doing on social or?
Is tracking.
Yeah.
For dot watches. In fact, people like dot watching. And it's the Freedom Trail. If you Google Freedom Trail or Freedom Challenge, you'll find it.
Okay. We're going to post. We're going to signpost people.
And are you doing any fundraising?
I was just going to ask.
The fundraising, there's a trust associated with the Freedom Challenge, and that's for children for education. So all the fundraising through the race all goes to that trust, and the trust puts the children through school and through university.
Fantastic. Bruce, thank you so much for taking time out of the meeting here and sitting down with us to talk about all these things again. We're going to put all the different links up. If they want to reach out to you or if people want to find other ways to support the work that you're doing and the team that APORG is doing, I'm sure we can link out to that.
Absolutely. I mean, people are welcome to email me and But thank you, Desiree and Monty. You guys are always stars. Thanks for spreading our message.
Well, again, as you learned when you did your own podcast, it's such a privilege and an honor to be able to share other people's stories. So that's wonderful.
Thanks, Bruce.
Yeah, thanks again. Thanks again for listening to Top Med Talk. Find more conversations with Bruce and all about APORG and the meeting here in Prato at topmedtalk.com. Thanks so much for listening. Bye.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.